Welcome everyone to Paging Dr. Robot, how artificial intelligence is revolutionizing healthcare. And I'm going to give you a little framework for what we're going to be talking about today before I introduce our panelists. Machine learning is being used to help doctors with understanding patients' outcomes. IBM's Watson has the ability to make a diagnosis. Apps can track and monitor patient emergencies. Our phones may soon be our closest medical advisors, if they're not already for many of us. Preventive and diagnostic medicine is on the cusp of an AI revolution that will no doubt save lives, but there are potential tensions between innovation and regulation. And when it comes to our health, should decisions be made by machines? Join us for a deep dive into this ethical and medical look at allowing AI to have a controlling stake in our healthcare and our lives. And to get some answers to these questions and to get the framework for what we're talking about in terms of technology and artificial intelligence, I'm going to begin by introducing our first guest, who is a technical fellow at Microsoft. He has served as the president of the Association for the Advancement of Artificial Intelligence and has been a long-term innovator in AI theory and practice. Beyond the core science, he's been interested in the influences of computational systems that perceive, learn, and reason on people in society. Please welcome Eric Horvitz. Come on out, Eric. Whoop. Our next guest is a consultant, ethicist, and scholar at Yale University's Interdisciplinary Center for Bioethics. He's also a senior advisor to the Hastings Center. His latest book is A Dangerous Master: How to Keep Technology from Slipping Beyond Our Control. He is also a co-author of Moral Machines, Teaching Robots Right from Wrong. Please welcome Wendell Wallach. Come on out, Wendell. Watch the stairs. Our final guest is a professor of cognitive, linguistic, and psychological sciences at Brown University. His research has been funded by the National Science Foundation, the Army, the Templeton Foundation, the Office of Naval Research, and DARPA. Primarily, he focuses on social cognition, moral judgment, and human-robot interaction. In 1995, he received the Society of Experimental Social Psychology Outstanding Dissertation Award, and in 1997, he was awarded a National Science Foundation Career Award. Please welcome Bertram Malle. So one of the things we want to do before we begin questioning our panelists is get an idea of who's in the audience today. How many people here are in healthcare? Okay, and does that mean you're working in direct patient care? How many have direct patient care? Okay, a few. How many of you here are into the computational aspects of this, the data aspects, or the AI aspect of what's happening in healthcare? All right, how many of you are in none of these things? You just think this is cool and you came today because it really kind of turned you on. Okay, okay. All right, is there anybody here who's in, I guess, venture capitalists? Who would be funding some of this stuff?
They wouldn't identify themselves.
They wouldn't identify, okay.
But those of you, don't raise your hands.
How many of you here are working in a startup? Is that a safe thing to say? One, oh, okay, back, two, okay. So I still feel like there's a couple more who haven't identified themselves. Would someone who has not yet raised their hand tell us why you're here, if you're not just an interested person or you're not any of the other categories? Anybody want to be brave? Yes, you right here.
I'm a cognitive scientist, but I work on human things, not artificial intelligence.
Okay, a cognitive scientist. There was one other. Yes, very interesting. Thank you.
I'm in user experience, and I'm interested in the interaction between humans and robots.
Interaction between human. Oh, good.
Can I just ask this
Sure.
audience, how many people here have been personally frustrated at some point with the healthcare system?
Ah, okay. Now we have unanimity. Okay, thank you. Okay.
How many have been so far frustrated with AI and robotics? All right.
Okay.
A little bit.
All right. Okay, so let's lay the foundation of what we're talking about today. And I'm going to ask Eric for you to start. And you had a dream a number of years ago the 80s. And there was a lot of talk back then about exactly what role artificial intelligence was going to play in healthcare. And can you take us back? And by the way, there's a secret about Eric that we all learned sort of at the end of it, which is that Eric is a physician he's an MD, PhD, but he works for Microsoft, and he works primarily in data acquisition and AI. Is that correct? For Microsoft?
I would say I'm an AI researcher.
AI researcher, okay. But he also has experience in healthcare.
Right.
So what were you thinking back in the 80s?
It wasn't just me, this was the community, and it's a long-term pursuit and dream in AI. It's actually a sub-area of AI called AIM, AI in medicine, and a passionate community of folks who have thought that computation, knowledge representation, automated diagnosis, planning technologies will basically have lots of riches to provide healthcare, to analyze data, to capture the best expertise on the planet and render it for individual physicians in particular cases to help patients out. The idea was these technologies could be applied in a variety of places. And in the mid-'80s, people may remember, if you were living in the mid-'80s, there was a...
That side of the room was not, I'm guessing.
Most of the room may be. That there was a boon and a set of expectations around expert systems. And one of the big applications was healthcare, capturing best knowledge and having like expert specialists, for example, providing systems that could help generalists understand details. And maybe you wouldn't need so many specialists, or you wouldn't have to wait so long for them, for example. We have a video showing me back in those days using a system that I could wear, actually, that would capture the latest and greatest in trauma care.
Michael? Set air movement, gross present. Set pulse, thready. Set heart rate, 135. Set systolic, 85.
So if we lower the audio on
Set
this, I'll just
45.
describe a bit of what's going on here. The idea basically is a system that has the best, that has expert knowledge from a trauma care surgeon is being used by a non-expert, in this case, me playing the role of a non-expert, which actually was a genuine role. And it was posting the next best question to ask and to assess, and using hands-free, it was a hands-free system displaying to me in a heads-up display and listening to my voice. And we had thought that by now, certainly by the year 2000, this would be more commonplace. And what's happened in many ways is that things have gone a little bit differently with the explosion of data resources, captured as the world has gone to kind of a digital economy, including hospitals now. Finally, most hospitals, they're not dropping data on the floor as they had for decades. With data and analytical tools and machine learning now to really start to address key or critical problems like readmissions management, like hospital-associated infection. Can we figure out how to best identify patients who are at most risk for being readmitted within 30 days? It turns out, one study showed that patients being discharged from hospitals, about a quarter of them are readmitted within 30 days.
And do people understand why that is such a big deal to the medical community? I'll quickly explain it, because first of all, Medicare will ding you. They'll now, since Obamacare, if you have patients, a large number of patients who are getting readmitted within 30 days after you've treated them, Medicare is now saying, hey, you guys screwed up. These people should not be coming back 30 days after you discharge them from the hospital. We're going to start to dock you pay because you didn't do the right thing the first time around. So the entire medical world has been scrambling to figure out ways to make sure when they let people go, they're in the best shape, and then when they get home, we're monitoring so that they don't come back to the hospital within 30 days, not just because it costs more, but because it's bad for patients. So there's been a huge scramble to try to find better ways to send people out of the hospital and make sure, or at least identify those who are at greatest risk for being readmitted within 30 days.
So it turns out that hospital errors, avoidable errors, are also an interesting challenge problem right now in healthcare. We read about shootings in Paris and problems in San Bernardino and deaths there, but we don't hear about the fact that almost 1,000 patients per day, per recent estimates, are dying in hospitals because of avoidable physician or hospital error. Okay, the latest study showed about 521,000 estimated. I thought that was a bit precise, but it's basically like the idea of a city the size of Miami or Oakland going away quietly every year with technologies that we could use to address these outcomes.
So to get us from you in the ER with the patient in the 80s to this present moment, what happened in those intervening years? What allowed you to begin to be so precise about the number that you give patients who leave the hospital and are at risk for readmission?
So we gained access about 5 years ago, maybe 7 now. Time goes really fast when you get older. To a large database, even before many hospitals started going electronic with the incentives from the Obama administration. There were some that had done some long-term work at collecting fine-grained data. We worked very closely with one such hospital that had 20 years, nearly 20 years of data with 30,000 variables in it, including things like all the physician notes and the diagnostic codes. They're called ICD-10 now. Lab tests, results, procedures taken, locations in the hospital, down to the billing codes and every healthcare professional that touched a patient we had access to. So he said, I wonder if we actually took a database that had coded which patients bounced back after 30 days, or within 30 days, I should say. Could we predict from a holdout set that hadn't seen the data yet, right? Predict which patients in this test set were going to come back. And we could do quite well with that. And that became a very a kind of a battle cry. We should be using this data. We should be harnessing it. It shouldn't be sitting locked up in electronic health records. It should be alive. It should be mined.
It should be mined. And there's been generation of data from all sorts of places now that's being used this way, not just in the hospital, but on the internet, correct? And maybe you can tell us a little bit more about where AI is going in healthcare and where you're getting that information, and then we can bring in our other two panelists to talk about
right.
what some of this means.
Because I do not want to dominate this conversation. So let's get to the end of my stories, and we can maybe talk about some of the issues that are coming up. So the people like myself feel the most comfortable in working with data that you might call largely, even if there's error in it and so on, and noise. Electronic health record data is crisp medical data. Several years ago, I and a couple of colleagues, but primarily a primary colleague I work very closely with, who was in information retrieval, Ryan White, started looking at search results and search logs. So Microsoft, Google, other large companies have access to the query logs, the logs of people's behavior as they enter search terms. They're anonymized, and we look at these algorithmically in large scale. So we don't sort of, we think we work with an ethics advisory board to make sure we're clear about how we work with the data, and we ask questions, and we get buy-off from our panels internally. But we discovered we could actually see signs, for example, in our earliest work, that people were getting, or a certain set of people were getting very anxious in searching on symptoms on the web. How many here have gotten anxious when they've done symptom searches on the web? You feel free to raise your hand.
Yeah.
Well, in this paper on cyberchondria, which we published about 5 years ago, we found the reasons for why this was the case. And if you want to read the reasons for why the web is making people typically needlessly anxious, you could read the paper that captures biases. We also got involved with our Stanford colleagues in detecting adverse effects of medications by watching, understanding in large scale, people who searched on a drug name, a medication name, and then later started asking questions about odd sets of symptoms that they were having, because people seem to whisper lots of things to their search engines these days, like, what's going on with the ringing in my ears? 3 months after they started, they were curious about a particular antibiotic, for example. And it turned out we could detect both previously unforeseen adverse effects, as well as, in a recent paper, predict a future FDA warning label change in advance by watching, even for rare side effects like liver failure, acute renal failure, myocardial infarction, heart attack, and gastrointestinal bleeding. We can detect people asking, why is my poop so dark? Which is a sign of certain kinds of bleeds going on. And so we can actually use this data in aggregate, in large scale, to make inferences. And most recently, I'll mention that we'll be announcing this, or a journal article will be coming out tomorrow afternoon at 4 p.m. It goes off of embargo. I was very excited about the prospect of helping patients by detecting devastating diseases earlier, if you're looking at search logs. Again, we're not talking about applications yet. We're talking about just feasibility studies. Because once you show you can do something, then you can say, well, what would I do with this? We can talk about the implications of various ways you'd field these technologies. But there are diseases like lung cancer and pancreatic cancer and other kinds of cancers that typically, as Emily knows, are caught too late. Once you catch them, it's often, we can't do anything about this. There's no operative outcome, for example. Cancer's already spread. And the question we asked was, is there a fingerprint of, especially with illnesses that present for months as time-stamped sets of temporal patterns or time-based patterns over non-specific complaints or symptoms that grow and grow and grow in terms of intensity, and the timing changes from a kind of a strange gnawing back pain to itchiness of various kinds. And typically taken separately, these would never be enough to worry a physician, and certainly not enough for a patient or we'll call it anxious searcher to run to the hospital or emergency room. And we asked the question, if we do this, if we use machine learning to find these needles in the haystack, so that months in advance we can say, even with some low false positive rate, which we'll tolerate, we'll say like 1 in 100,000, can get a bunch of these people months earlier. And the answer was, yes, we can. And so this excited us in terms of possibilities. And I'll mention one more example now, which I think we have a slide for on postpartum depression.
Yes,
and then
absolutely.
We'll move over.
We'll talk about.
Let's put up the slide about the postpartum depression work. This was work we did with a postdoc that was at Microsoft Research, Munmunde Chudri. And she is doing work, she's now at Georgia Tech, and she's doing some fabulous work on looking at social media. By the way, this whole area is referred to with different names. One name is called digital diagnosis. People are using this phrase now. It's not just search logs, but it also involves looking at social media, Facebook and Twitter, if you have permission with Facebook, of course, and those studies involve permission granting by volunteers. But Twitter, there's lots of public tweeting going on, of course, and researchers have access to large corpora of tweets. And so we asked the question, Moon and I, and Scott Counts, another investigator, could we detect women, first, gender, who were pregnant, and then follow them on Twitter, and then could we detect the birth of their babies? You can imagine if you're a tweeter, you probably will tweet that Bradley was just born, and he's 8 pounds 15 ounces, and everyone's healthy and happy. Well, it turns out that the CDC believes, and evidence shows, about 15% of new moms will go through either a period of postpartum blues or severe depression over a period of 2 years after the birth. It's also believed, per CDC, that about half of these cases are just never reported. The mom struggles with challenges about being a new excited mom, but facing a severe depression, all quietly and to ourselves without necessarily getting professional care or support, maybe even not knowing what it is. And so we asked the question, after we did this detection, which we could do, and this was a paper several years back, the second question, which will make, I think, frame some conversation, is this. If you had a training set of people who gave birth and then showed several different dimensions, we have more dimensions, the volume of tweets, the replies, negative affect, activation, and the use of first-person pronouns. Let me just explain this. What you're seeing here is our 5 dimensions here. Each row is a different, we believe, pregnant mom who just had a baby. The baby birthing is that little light line in the middle of each of those columns. And you see a change, for example, and we're sorting by the most people who are changing the most in different dimensions here. So we see people who have changed in the volume of their tweets, how much they reply to others. The negative affect, we have linguistic measures of negative affect that psychologists like Jamie Pennebaker at UT Austin have studied for many years. Activation level, and the use of, turns out that James Pennebaker, if you're interested in his research, has shown through what he calls the Luke index, LIWC, that there are words, first person, third person pronouns and shifts in these that can be taken as credible indicators of depression or negative affect. But we found a way to tag people as to who were likely showing signs of postpartum depression. And here's the ringer. Could we go back in time before the birth and using machine learning, automated statistical procedures that give us classifiers, to predict which women who look fine now, by all accounts, for the measures, who are at highest risk for after birth going into postpartum depression. And we have a paper that shows, yes, we can do that with some reliability.
It's all good, right, Wendell?
I wish. I wish. I think it's hard for any of us to debate the desirability of early detection, of the use of diagnostic systems that would improve the diagnostic rate. We know that there's roughly a 15% inaccuracy in diagnoses. The detection of new treatments, looking at massive databases of individuals with similar conditions and finding out biomarkers or at least data points that we can then apply to the rest of the population and see whether that indicates that they have a high likelihood of having that condition. And the fourth aspect I think we should talk about here is what's been called personalized medicine or precise medicine, which is these large databases are helping us look more closely at the fact that we aren't all the same. We have very different bodies, we have very different propensities for different kinds of conditions, we live very different lifestyles, and it would be nice if we could target the appropriate treatment for people. That becomes a big issue, for example, with cancers, that you can be put through round after round after round of chemotherapies, but none of them is effective. So it would be nice if through genetic markers or other factors we could distinguish which of the chemotherapies would be most likely to produce a cure for you if you went through that regime rather than going through 3 or 4 or 10 regimes and having poor results. And there are even other areas where we're now seeing that that certain people have the chemical pathways, the metabolic pathways where certain drugs work but other drugs don't work. So Dr. Gilbert Ruano up in Connecticut, he discovered this for depression. And the people have been on antidepressants for decades even with a class of medications that just won't work in their bodies. They don't have the correct biomarkers for that. But the difficulty is to distinguish that you need to go through a genetic test, which have become cheaper and cheaper, look at 3 specific genes, and the insurance companies have to pay for it. So here, let me shift into, here's where the difficulties come in. The insurance companies have been loath to authorize these kinds of genetic tests because they think that a lot of them will be frivolous. And therefore, you almost have to prove to them in advance that this is not a frivolous test, and they have to understand that it will lower their costs. Secondly, let's talk about costs, because I've lived a lifetime now where all these technological costs are going to lower healthcare costs. But the reality is it never happened and probably never will. So in the United States, we spend over $3 trillion, roughly $3.05 trillion every year on healthcare. That makes our healthcare budget alone larger than the total gross domestic product of France, and only $0.5 trillion less than the gross domestic product of that powerhouse Germany. Furthermore, we get less bang for our healthcare buck than almost any other country in the world. And to move on, the argument has been that technology, not just these digital technologies, will lower our healthcare costs. But what's happening is healthcare costs grow at 6% every year, and roughly 50% of that is technology expenses, either the adoption of new technologies or the proliferation of existing technologies. Everybody wants the best healthcare, so every hospital and every clinic should have an fMRI machine. The difficulty is those are very expensive, and there's probably no reason for every institution to have that. But if they don't have that, or if they don't have the latest robotic surgery, you may not go to that healthcare clinic because you think that these technologies are what we need. And just to bring in a third dimension is all of this technology that we've been talking about so far depends upon access to information, getting that information. And what Eric did not mention is that simultaneously with the growth of this vision of the power of data has also been the growth of concerns over the security of data and what will happen with our healthcare information. And you may say, I don't care, but would you say, I don't care if you had a serious condition and your employer had easy access to that information and fired you without mentioning that that was the reason that they were firing you, because of access to that information? So security of data has been very important. But the security of data has gotten in the way of centralizing healthcare records. It's gotten in the way of companies that really want to do this kind of research and come up with new cures in having access to large databases. And it gets in the way of just individually getting into you or somebody else to agree to have the kind of monitoring, for example, that might show well in advance whether you are subject to postpartum depression. We can go on, and hopefully we'll cover more, but let's give...
So you're talking about the concerns about how this data is gathered and what happens to it, correct?
Right.
Bertram, you bring in another dimension yet still, is that now we've got the data, we've used it, and we're now placing it into the active sort of patient care environment. You bring in yet another dimension about what are some of the concerns there that most people would never think about.
Well, I want to add one piece to Wendell's statistics, and that's a very important one, that much of the high costs in the US healthcare are services. That is, people doing actually things for other people. Now, one radical perspective would be to say, well, we just have to cut a lot of personnel costs, and then it's going to be fine. And that's, of course, what many people also fear, that robots will replace the doctors and the nurses and so on. But the other perspective that we might be able to take is to say, in many cases, these services are inefficiently provided. In many cases, they are not even reaching the people who actually need them, geographically or because of lack of finances. And if we can use artificial intelligence, and especially maybe agentic artificial intelligence as forms of robots, to extend the reach of doctors, nurses, and so on.
Can we show maybe some of that? Would you speak to that?
Oh, the front
Yes,
of the video.
sure.
Yeah, we can maybe take a
Okay,
quick
so
look at
why don't we give an example of what we're talking about?
One of the main reasons why people with impaired mobility are no longer able to live alone in their own home is fear of falling and the related consequences. This risk can be addressed by the installation of a fall detector, which sends an alert in case of an emergency, allowing assistance to be promptly provided. In that case, Care Robot makes its way automatically to the place where the fall has occurred. At the same time, the service center becomes involved. Trained members of staff are able to use the robot's cameras to make an initial assessment of the situation and to talk to the person who has just fallen. If necessary, they can immediately call an emergency service and also provide the necessary patient information, such as recent blood pressure measurements or information on any allergies. While waiting for the emergency service to arrive, staff at the service center can act to calm the person who has just fallen. Alternatively, they can instruct the robot to fetch the person a drink or a pillow until help finally arrives.
Now, I should say, this is trying to paint the picture of technology being useful to help people, but you wouldn't actually want to have a $5,000 to $10,000 robot to do this. You can have a lot cheaper technology as fall detectors. You can use your iPhone, and you can use other very simple things to deal with that particular problem. But what this company and others try to illustrate is that to have somebody or something there in the home of an elderly person might help with a number of needs and problems that right now nobody else can meet. You can't expect the daughter or son or a nurse or a doctor or the neighbor to actually be there to, for example, provide some company to these people who suffer from enormous loneliness, often loss of self-worth, and when they have a need, might be embarrassed to actually call somebody. I forgot where my reading glasses are. I don't know where my house keys are. A huge number of people in the US and in the world suffer from early stages of Alzheimer's. We all become older and so old that one of these problems are going to afflict us. And small things that are embarrassing to admit actually limit your ability to live alone, or at least live in some way at home. And this is the number one desire of all people who, as they get older, to stay at home as long as possible. But you can't do this without some help of technology. And so in addition to what I think really is an extension of really good science, all the predictive models, we've done this for a long time. They have been called regression models, and now they're sort of huge data mining of deep learning, machine learning. But the fundamental principle is the same. You use data to make predictions and then make likelihood assessments. You probably have this problem, and there's a chance that we might help you with this. This is a wonderful extension of what we've already done. But the really new technology that would change, I think, how we interact with the healthcare system is when additional agents are being brought in, artificial agents either on screens or physical agents that might be in our homes or that might be in the welcoming center of a hospital. And again, my hope is not to replace those who are already there, but to complement what they are doing best and thus provide, in a sense, more health care for more people. Now, that's my optimistic side. We can easily go to the pessimistic side as well, but right now, let's keep it at that optimistic moment for.
Did you want to say something, Wendell, or about the optimism, what the ideal is, and how to keep it going in that direction?
Right. So I was going to make the comment that I take Wendell's comments to heart very deeply about the expense of new technologies and on the diffusion of technologies and the fact that that can be limited too, as well as comments about the opportunities for doing new kinds of things. I do think that a really great domain application area for AI is in managing the cost benefits in a very explicit way. So we can get a sense for, even through simulations in advance of fielding technologies, the actual real world costs with a real world fielding in the open world versus always the trend to introduce a new expense. So just like in AI, we've had layers of reflection that make sure that the combinatorial explosion of planning algorithms is managed. We should apply these same ideas to managing the costs in healthcare explicitly as a very important role, not just diagnosis, not just better disease management, but also managing the costs and benefits of technologies and understanding them. Now, one other comment to supplement what Bertram was just saying, and we can imagine new kinds of triaging technologies, new ways to have automation to assist human physicians. especially as per Wendell's comment, places where the technology is not available. And I wanted to roll a brief video of a system we built several years back. Now, you'll see something that's relatively clunky, but try to remove the clunky aspect of it from your minds, because we can be much more fluid and smooth about these technologies these days, especially. But we're actually going to show how we fielded what's called a Bayesian network model, built by someone who was known as the Pope of Pediatrics, Richard Berman, one of the co-editors years ago of the Nelson's textbook in pediatrics, and he built about 15 to 20 models, each looking for a chief complaint and then helping to diagnose the problem in a toddler or baby. And let me show you this example of what happens when we try to apply this with a dialogue model.
Hi. Namaste. Popkaswagant hi. Thanks for coming to the triage kiosk. I'm in touch with the best doctors in the world. Are you here for your child or yourself?
For my child.
So how can I help you?
He's been having diarrhea.
Oh no. Sorry to hear that. Hi there. What's your name?
My name is Manav.
And how old are you?
6.
So, 6 years old, right?
Almost 7.
Okay. 7 years old. Have you felt nauseous?
I don't know.
I'm sorry. Has your child been vomiting at all?
No.
Okay. So let's see. Has there been a fever?
A slight.
Have you been feeling tired lately?
Yes.
Let's see. How about abdominal pains?
He's not complaining about that.
Has your tummy been hurting?
Yes.
Oh, I'm really sorry. I hope it will feel better soon. Okay. Has your child been losing weight lately?
No.
That's okay. Have you noticed whether your child's stool looks funny? Is it black or darker than usual?
It's darker than usual.
Okay, let's see. Considering everything you've told me, I'd like to schedule an appointment with the doctor, just to be sure. However, not to worry, I'm not that concerned at this point. Can you bring your child to see the doctor this Friday at 10 a.m.?
Yes.
Great. Hope you'll feel better. And we'll see you then. Bye-bye.
Bye. Thank you.
Now, that is a nice example of reach that would otherwise probably not be possible.
Right.
And I think it's also a nice example of that idea, the decision process, that if it's not necessary, then it shouldn't have to come to the hospital. It may turn out that he ate a little bug or something, and then it's fine. But if it's necessary, then the additional costs, both the emotional cost as well as the financial costs, are worth bringing the child in with the mother. So I think this is a nice example of how to make the decision earlier and sort out many of the unnecessary hospital visits that really also drive up the costs and are also just really, really stressful to people. Not knowing that something might be happening. If you are at the hospital, you wait for 2 hours with this uncertainty. So that's an additional cost that usually isn't factored into the dollar calculation.
What's wrong with this, Bertram?
I mean, Wendell.
I'm sorry. Yeah. Wendell, sorry.
Well, I think we can all agree that some care is better than no care.
Wow.
But there's an obvious response that I think many of you had, just a discomfort that this robot was supposedly engaged in some form of pre-diagnosis.
Were you guys, how many here would be comfortable if you had a little something bothering you, the robot either put your mind at ease or sent you right away to the ER? How many people are okay with this as a first interaction with a health system? Well, let's see. Would you give it 50% or less than 50% of it?
Yeah.
Yeah. So not everybody is good with it.
Not everybody is good with it, and understand also that this is one snippet of what may happen much more broadly.
Right.
So this is one snippet about whether we are creating greater distance and also taking out the human component, which seems to be also very important in the healing process. So the practice of care has developed with all kinds of rich roles being played by different humans. And even if you bring a robot in to fulfill one function, you may radically alter the practice of care.
But some of the robots are better than humans.
And some of the robots are better than humans, and this becomes problematic. But the difficulty is, for those of us in wealthier situations who may not get any care at all if we don't have this robot, will we be satisfied with the robot giving us some care, and what will we need for that satisfaction? We all have the illusion that we will have the doctor, or the doctor we have selected as one of the greatest diagnosticians out there. The reality is most of them aren't that great. They're good, but they aren't that great. There are some truly superstars of diagnosis. So we are seeing now that many of the diagnostic programs are better than the average doctor is in determining what your condition is. But again, is it satisfactory to have that all taken care of through the system alone? You interact with the robot or the database at your home terminal, or would you like to have a nurse there saying, oh, well, you have a terminal condition, or at least a doctor or something like that?
So I'll make the comment that the last part of the video, which we didn't see, shows, and by the way, I take to heart everything you said, but shows the human connection where a physician receives the actual video and receives the list of observations, signs, and symptoms, and is all prepared for the mom, and the kid who come to visit the doctor's office that Friday. The question I have often is, as Wendell was pointing out, is where does it, let's say the technology is successful, this kind of thing where people expect this kind of working with a kiosk to do initial triage, even if works quite well, and it spreads and it's cost effective. And that becomes the way, since most, thankfully, most symptoms and concerns typically are not serious. Becomes the way that most of us interact and engage with healthcare systems and online forms of various kinds, and interaction experiences. Is there a loss of the human touch that might be more expensive, that might be desirable, and what's the cost benefit there in terms of where things are going?
But let's not think about it as necessarily everything replacing that we right now know is the human touch, which, by the way, is usually not really there, with technology. Right. But rather think about it this way. It is not pleasant to go to a doctor's office. It's not pleasant to wait for 4 hours. It's not pleasant to go to a hospital. Even if you then hear, oh, you just have a tummy ache, and then you go home. That whole phase, that was not human touch. That's not something that I or anybody else would enjoy. If a phone call, a Skype call, or an interaction with an avatar can take care of all the cases that are actually relatively harmless, or I, my spouse, my family can take care of with me, that's great. When it's really serious, then I want actually to talk with the doctor to get a few minutes to get an explanation of what's going on. And the idea would be that you free up these professional caretakers' time to then really be able to treat these patients. But many of you are either doctors or nurses. You know that you never have enough time to actually talk with people. And this is one of the major problems. There are things that you could just basically offload. You wouldn't want to offload everything, but you want to offload some of the things that would then allow you to really interact with your patients with a human touch, giving them actually the information that they would want to know. That's the ideal way.
That's
to
the
shift,
ideal.
and that it's the complementarity between technology and humans rather than a form of replacement.
Well, I personally agree with all these ideals that we're mapping out here. I just witnessed that there get to be all kinds of problematics in the real world when you're dealing with people. So if you were given the choice of going to the kiosk or talking even with just a nurse practitioner, if not a doctor, would you make the choice for the kiosk? And perhaps with some education, a larger and larger percentage of us will. We don't know that yet. I personally wouldn't mind doing that if I could do it from my home and I didn't have to go to the bloody institution when I'm really not sure whether I've got a cold or, or flu or something more serious is going on. So it would be nice to have some of that filtered out. But that gets us caught up in what is projected as the next level of this, which isn't happening yet. And that is personalized medicine or home medicine, where you get a massive plethora of data about yourself. So consider a situation where, number one, you have your personal genome analyzed. So you know what all the genetic information is. And number two, they've also looked at your gut flora and fauna, which are a very major factor in predicting what your health condition would be. So we're talking about the bacteria in your gut, which really outnumber all the cells in the rest of your body and even have a genomic character that is so far more complex than what we have in our individual body. But you've had that analysis done. And number three, you know what the basic standardized biomarkers are for you. Not for everybody else, but for you. What on a healthy day your condition seems to be. And in the morning, you give a little spit on a chip, in effect, and it analyzes it, and it tells you how much you're digressing from the biomarkers. Now, what are you going to do with all that data? Some of you may feel you can manage it, but what happens if it says, well, you have a 54% chance of having this and a 32% chance of that, a 75% chance of some other condition, on and on and on and on. And given your genetic markers, we need to be particularly concerned about this, so that might raise that by 10%. When do you know, and will you be able to manage this data, and will even a computer program effectively help you manage all this information? So this is becoming this other level that is already appearing within the hospitals because they have so much data and so little time to address each patient. But it's moving into our homes.
So one of the things each of you emphasized is that this is not years and years down the road. You all are talking about an explosion in all these things: personalized medicine, genetic information, artificial intelligence, the use of robots, in the very, very near future. Is that?
Quick statistics. Just at the end of last month, sort of an industry monitor consulting firm counted more than 60 startup companies in the AI healthcare industry. End of February, they counted 30. Now, add the distribution around this of uncertainty, but this is truly exploding.
And that's just the US, by the way.
Exactly.
Let me make a comment that brings together what Wendell and Bertram just said. So I was an early aficionado of the 23andMe experience, the original version of it, where you got your risk scores and so on. I found that very interesting. We did it. I bought gifts for family members, and so on, who were willing to do this kind of thing. And we got lots of our family coded up with the single nucleotide polymorphisms, the SNPs. Just recently, about 6 to 8 months ago, I got involved with Leroy Hood's startup in terms of being a user. So he has a startup in the Seattle area that is doing flora, full genomic sequence, like the full deal, like the one that cost $1.5 billion a few years ago.
Right.
And cortisol tests and very fine-grained blood tests, and doing it longitudinally over time, and making recommendations, gathering lots of data from all their users, and making recommendations, not about like, oh, you have a 10% chance of X, go run to the doctor to get, for more expensive tests. But it's aimed at wellness. It's aimed at wellness. What could you do in your life? How can we'll say right now, leverage AI to live longer, healthier lives without encountering or lowering your risk scores for things that you already have the risk of transitioning into, like diabetes, for example. So I discovered a whole bunch of things about myself, which I found very interesting. Of course, there's uncertainty about some of these inferences still as data is collected. But as we collect more of it, we'll know more. But I've already made several interventions. And we're going to actually, over the next several months, be checking whether those interventions, if they're causal, have influence on some of these factors and observations about my gut flora and my blood and my DNA.
So this is going to happen in an explosive way. We all agree on that. But Bertram, you were talking earlier about before the cat gets out of the bag, there are some things that we should be thinking about that we haven't considered yet. What are some of those things? Some of the caveats that are going to confront us as this AI and all this sort of technology really becomes a part of our day-to-day life, and a lot of it isn't as refined as we would like, or doesn't provide you with all the answers to its value. First off, it's going to be a little crazy for a while.
Right. So to me, there are really two dimensions to this. One is a more global, if you will, a sociological one, and then there's the individual one. At the sociological level, it's the huge disparity of economic and other access that is only going to get worse. Right now, robots and some of these specialized predictive systems are available to people who have a lot of money or a lot of knowledge to even deal with the information. And the question is, are sort of market forces and companies going to reach into the other domains of our society? And that's one of the worries I have, that this technology accelerates very much, but in an asymmetric way. Now, I think it in principle has the capacity to actually reach into the domains which people don't have much money. But we have to make an explicit effort to do so. And sometimes, with all due respect, I'm a little worried that market forces are not very likely to do this because they need to make a buck. Whereas science and maybe not-for-profit organizations are more motivated and can afford to do this. So I think the collaboration between these different institutional structures would really, really help to, I think, make us feel a little more optimistic. So that's the broader sort of sociological level. At the individual level, we have a number of challenges, and Wendell already mentioned the big challenge of privacy. And another one is of autonomy. So you don't want to overhelp. A human who cannot do much at all, who constantly gets help from others, as I mentioned earlier, might become embarrassed and just really feel bad having to ask for the simplest, smallest things. So a first move is to ask a machine to do some things that you would not feel embarrassed about. But the next level up is also that these machines should not take care over every life task. Well, right now they can't. They can't even put a glass from a table into a dishwasher most of the time. But they can help you and, again, complement you in some of the life tasks. And we have to think about how you encourage maybe the human, the patient, the human user, to activate the things that they can do. And we're doing a project, I can't talk a whole lot about it, in which a very simple robot tries to actually get the person involved. What the robot can't do, the human can do, and vice versa. So that helps with the challenge of autonomy, that some autonomy is there and that should be harvested. And then the third one is, of course, the relationships that people have with this technology. And we have some relationships to our computers and to data systems, but those are relatively limited. Once something is there in 3 dimensions, and moves around, and maybe has eyes, and maybe talks to us, we do treat it as a being, as a mechanical being for a while. But we begin to treat it as having some form of mind. And we cannot help do this. That's a natural human response. So we have to be very careful as designers, as researchers of these kinds of relationships, not to promise too much, not to give the user the impression that, oh, this thing understands me, and this thing loves me, and I love it back, and we have a relationship. And then suddenly they take the head off because it has to be repaired, and I have grieving as my emotional response. You laugh, but that's actually very likely. So we have to really think about that dimension. If we put machines into the cycle of the individual patient, the family caregivers, and the professional caregivers, how can that machine be part of that in a relatively harmonious ways? Because relationships will exist. The question is, can we manage them, monitor them, and in a healthy form, live with them?
I often talk about these individual care aspects, but I'm not going to for this discussion. I think we can sort of, break it up a little bit in terms of what we each focus on. And I'm going to talk a little bit more about the whole socio-technical world that we have created here and whether it functions well with these kinds of apparatuses. I mean, first of all, not only does healthcare grow at 6% a year in the United States, but it's already 18% of the gross domestic product, and it will be 20% by the end of this decade. And if we implement all these technologies we're talking about, it could be much larger within another decade or so. And that's not possible. It's not feasible. It breaks the bank. It will destroy our economy by itself, and if our economy goes, that has reverberations throughout the world. But the problem is, we as a society are caught up in this. We have to feel good, we have to get the latest treatment, and we are not using our healthcare buck wisely. So unless we become wise consumers and a wise society, we have broader challenges that are going to come up in it. Everyone does not need robotic surgery. In fact, in most cases, good surgeons are as good, if not better, for most of the conditions that the robotic surgery is used for. So we don't need to demand these kinds of expensive procedures. But more importantly is what is going to be our attitude toward health and what can we be satisfied with? First of all, it seems that 2/3 of the healthcare dollars are spent for 1/3 of the population. And that's a disturbing statistic because people who don't think they're going to get sick want to buy out of the healthcare system. And that breaks down the money that goes into healthcare overall. Also, a very high percentage, which is very hard to exactly determine, but we know that the largest preponderance of healthcare goes to people in the last 2 years of their life, and even the last 2 months of their life. And a lot of that is about keeping people alive, keeping loved ones alive for an extra week or a day or whatever. And we need to get into a different attitude toward life and death in our society and move away from being so afraid of risks that we take too many antibiotics and breed superbugs and we want every last procedure even though the doctor is saying to us that this is a futile procedure, or maybe the robot says to us it's a futile procedure.
The robot is the death panel.
Yeah. But who's going to listen to that robot telling them that? You're going to go until you find a doctor who says, no, I'll write that prescription for you, or I'll give you that procedure. So it's important to note that we aren't just talking about the glories of what AI can help us in improving healthcare, or the kinds of care we can give individuals who might not get the one-on-one touch by putting a robot in the home. So let's say the elderly can stay longer in their own homes, which is certainly going to be healthier for them than going to a nursing home. But we need to think through this whole system of healthcare, which is already here and which is coming into being and which is being nurtured through these wonderful, remarkable possibilities, but not necessarily being nurtured into creating a system which is truly maximizing our overall health.
Let me make one comment before I guess Emily's going to get up and talk,
Sure.
involve all of you in our discussion, which we're looking forward to. And that is, we're conditioning lots of this conversation on healthcare, disease, diagnosis, and recovery, and or death, and how we deal with death and preferences around that. But I really believe a huge opportunity, and it's an obvious one, it's the big elephant in the room, is wellness.
Yeah.
You know, we know already that some basic factors, good nutrition and exercise, go a long way to reducing healthcare costs that give us this kind of profile where we stay healthy and then crash fast at an old age, versus chronic diseases like diabetes and heart disease and other long-term expensive illnesses and these short-term end-of-life situations are linked to our behaviors. And so how could AI better understand risk factors, better advise? How could systems persuade people to change behavior? This is a large area of application in how our systems work with us, robotic or online. And understanding best practices using machine learning and reasoning and decision making on things like healthful living.
All right, who's having some questions, some concerns, some feelings? I'm going to start over here. This works, right? Yep. And I think we have our other two. Okay, we're going to get to all of the room as we go. Go ahead. What's your question?
Hi, my question is, it seems to me that...
Maybe talk a little closer to it.
Can you hear me now?
Is it on?
Is it on? Yeah, now.
Yeah.
Okay. A lot of the science is, it seems to me, it doesn't take into account ecological framework where you change one thing, something else is going to change, and it's kind of like a dynamic thing. There is no final solution. You do one thing, you have to keep constantly. So for example, my mother lived to 104,
Wow.
and she was very resourceful in her. She had very simple things. She did things like cutting pills in half. She had just a simple one of these monitors, a Lifeline monitor, and that if you increase the level of dependency on technology, that it actually can have an adverse effect. Even mentioned, for example, doing searches on potential diseases can actually create psychologically the thing you don't want. It aggravates. I was wondering if you have any comments on an ecological framework.
Yeah, it's great. Let me mention a technical dimension there, which you might find interesting to this audience if you're interested in AI. So that readmission system I mentioned that identifies patients at most risk when they leave the hospital, and that guides selective attention and resources to patients at highest risk, for example, to minimize their readmission, is having an influence on the larger ecosystem of patients. It's shifting the distributions. So these patients tend to be revolving door patients. You inject an AI system into the mix that's disrupting things a bit, creating ripples. Is it modeling those ripples itself as it shifts distributions of who's coming in? For example, we don't know yet. Does it, for all its benefits, is it leading to some patients that come in 45 days, not 30, so there's no penalty, for example, but are much sicker now, or because some scaffolding in their lives was given and it held them up to a new height and then let them down more quickly. So we're not even modeling the influence of some of these systems on the world that they're immersed in. However, that's an area of research in itself. But I love the idea of thinking simply, even taking less medications if we can get off them, and so on. But there might be applications still in that pie chart of possibilities for where we can save lots of money and make people better and healthier, or do more effective surgeries on them when they're needed with these technologies.
Question, there was a question here. This gentleman in the World Science Festival t-shirt, red t-shirt.
I'm a health economist. I'm very interested in the implications of what you say. And it seems to me that we could, if we are screening sufficiently, we may end up having a surplus of physicians, or at least not very busy physicians. And physicians are well known for being able to make sure that they get paid. So,
but not well. Yeah.
Many of them get very well paid. And on the average, I would say that not well is not a big problem. But as these things change, how we pay for care is going to have to change. I mean, and we're going through a shift right now as a result of certain aspects of Obamacare that, as you all know, I'm sure, they are not easily, the system is not easily responding to the changes of trying to improve quality of care. How, you've talked about all the other aspects of it, and some mention of the economics of it, but does anybody think about that? Think about how would we pay for a system with this that becomes more and more automated, and who pays for the automation and that sort of thing?
Well, the naive belief has been that the benefits we get from introducing these systems will pay for, but there's been no evidence that that's been true throughout history. And not only that, we're getting into other dimensions, and I hate to make this even more complicated, but I'm going to take the 20,000-foot view. Because on one level, it would be great if these home systems allowed those of us who really cared about wellness to monitor them in ways in which we knew we needed a little bit more nutrition or exercise or whatever the basic factors were. But if it turns others of us into hypochondriacs or cyberchondriacs, that's not particularly helpful. And if wellness and the response to healthcare concerns move in the direction of life extension and radical life extension, which is another project that's going on simultaneously with everything else we've been discussing here, then we have issues around overpopulation. Or if robotics moves in a direction where it does become a downward pressure on jobs and wages, then who's paying into the economy to support the healthcare system? So I think you get that there's these waves after waves after waves
Unintended consequences.
unintended consequences. So the disruptive technologies are actually disrupting much more quickly than we're able to assimilate them. And the challenge is that we begin thinking about that in a more integrated way.
Let me
Go
just
ahead.
make a comment that I like going after low-hanging fruit where I see win-win. CHF, congestive heart failure, 10% of people over 65 will, if things go the way they're going, will have to grapple with congestive heart failure, is a $35 billion a year challenge. A lot of it is readmission, by the way. I'd like to go after those win-win situations, start with the big ones. Hospital-acquired infection, another $30 billion challenge. You know, it's basically, 1 in 20 people get a hospital-associated infection. 5% of them die. It's very expensive when they don't die, and of course it's expensive to the world when they do. There's some win-wins that I will talk to Wendell about afterwards that I think will have very few side effects in terms of cost explosions, will be largely contained costs.
I do agree there are these win-wins.
And I want to start there.
And don't want to give the impression that any of this is meant to squelch the things I'm bringing are meant to squelch where there really are wins. But it's just we should not go through this naively and buy into all the hype.
And even when I see win-wins and we go out, there might be ripple effects and things that unintended outcomes. So we want to be cautious too at the same time.
We have a question here in the back. Yeah.
Hi, I built a data warehouse that had 2.5 billion rows of Medicaid claims data, and I'm rather familiar with federal quality improvement options. The dark side of all of this data accessibility is that hospitals are now starting to restructure their service delivery models to avoid the federal penalties. They're making much more stuff ambulatory. They've created something known as observation status, so patients aren't admitted. This has radical cost-shifting effects to, for example, Medicare patients who are now treated as outpatients are not eligible for rehab, and on and on. I would also say, talking about the electronic health records, which were deployed as a national initiative with no requirements or standards for data sharing, that, let's say, NYU has the EPIC system and Mount Sinai has the EPIC system. They cannot share data. Clinicians are complaining horrifically that these systems were designed for billing, and all of the clinical add-ons are terrible. And the impact on the patient interaction is that clinicians are interacting strictly with the computers and not with the patient. So there's a whole other side. My last comment is the statistics on the medical errors. If you really go back into that study, you will be horrified at what crap it is. There have been analyses of it online on what they extrapolated from.
I've read the studies, and I've looked at even the Institute of Medicine report, which I thought was done quite well, said 100,000 deaths per avoidable error. The latest study I thought was quite good. The patient safety study, if you part of the detail here is how do you define an avoidable error, and so that takes a bunch of effort. Calling it crap really would lead people to believe that we don't have a tremendous problem with healthcare error.
It's equivalent over the actual numbers.
Right.
So let's not do,
the numbers are huge.
Yeah. They're big,
But
whether you believe the
I want to
latest
get
study or
back,
not, yeah.
so I will not take my attention off that problem, but put it this way. But let me go back to what you said, because I think that you've brought some really, really great questions as to unintended competitive and economic effects and of incentives and preferences, and how Medicare and government will push one way and then the soft balloon pops another way in terms of the reaction, and we don't typically know how to model the complexity of all that. It's a really interesting question. I'll just take that as a really great way to frame maybe as we speak, the conversation we're having today. This idea of the sharing of data, what a great comment. There are two dimensions there. So on a PCAST working group study that I just finished a few months back with some colleagues, we called out to the government per funding agencies to really think through standards and interfaces and modules that would allow and enable sharing among medical centers collecting data. The second part there is the legal issues of sharing data and how that can be made easier while protecting patients. And that's lego-technical in terms of the challenges there. It's an area that I'm extremely interested in. We see, for example, if we build classifiers, predictive models for readmission, based on, with the community, on all the VA data, which has been unified, by the way. Believe it or not, the government did a great thing there. And so people have studied taking a lot of data from multiple sites. How well can you do versus a single hospital? Yes, you can do much better if you have more data. We can see the implications of that on healthcare. But what are the interesting issues of data sharing and altruistic sharing by patients of their data? What does the law say? The NIH right now says if they fund a study that involves medical data, it must be shared. HIPAA says you can't share this data without special machinery. I once asked someone giving a talk at a government agency about this sharing and the HIPAA laws. I said, what do you think about that? And his response was, two locomotives going full speed towards each other.
Well, yes.
I just had a quick question about the liability of robots, especially since they're going to be based off of like humans and doctors who are looking at patients. Like there are some times when doctors may notice things that a robot may not. So say if, going back to the movie example of the child with diarrhea, say if the robot had missed something and something like the child dies or something like that, who is responsible for that and how do we take that into account?
Yeah, these questions are hugely important, difficult, but in most of those cases, you start with sort of a slow extension. There is either a hospital or a doctor or a group of doctors behind this avatar, and there has to be monitoring during the development of this system and while the system is deployed. And in the first phases, you actually probably need a few people constantly there if you do it right. And then over time, you can probably create something like warning systems. There might be 20 or 30 of them deployed. And there are certain cases where the uncertainty, the probability distribution is suddenly more like 70%. And you want to check in on that one. Just like we also do this as users. When you call your favorite airline, sometimes you have just a question, the system can answer it. I actually prefer to go on the web. And then typically after 10 seconds, I just say, agent, agent, because I don't want to talk with the system. And you need to have that option.
Right.
So if you are uncertain or if you don't understand what the system wants from you or tells you, you have got to be able to talk to a person. And I think this is the key element that also Wendell brought up. If half of the people want to use it and half of them don't want to use it, then we really need to provide those two options, because you can still get savings and maybe comfort for those who want to use it, but still the option for the other.
I have to say, we just to riff on something that Bertram just said, we built the system years ago using internal Microsoft call data. We have an automated receptionist at Microsoft to route calls and so on, and it took a lot of data, and it figured out, it tried to figure out in advance of somebody saying, operator, operator, hitting 0, to quietly say, you know what, I'm going to transfer you to the operator.
Your voice tells me you are agitated.
It used many features and how many steps into the dialogue it was.
There was actually work done on that in the affective computer lab at MIT under the direction of Ross Picard, who's often talked about as the mother of affective computing. But it was exactly this. It was, making sure that you put in the system that would know if you were irritated. And some of you do hear it now. It's that, Would you like me to transfer you if he hears your voice
By the way,
go up or your
so
frustration go
back
up?
to this cost-benefit notion we're talking about with healthcare, back to that example, there's a bevy of operators, humans, and they're busy at with different working loads, which leads to different wait times in quiet with music playing, and you have somebody struggling with a spoken dialogue system, and you have a sense for we're continuing to predict from lots of data this call is going to fail to operator. It's going to fail to operator. It's going to fail to operator, but we know how long the wait will be. Depending on the load, we want to do a cost benefit and do an ideal transfer. So just same place to health.
Question way in the back.
Thank you for your time. In terms of the optimistic or pessimistic trajectories of healthcare, there's rightfully a limit on the government to impose moral law. Meanwhile, technologies propagate largely through financial advantage. My question is there an unprecedented opportunity to harness digital media so as to educate the public in order to create a societal culture that optimizes us towards the correct probabilities of what could happen?
I think there are two elements to your question. One is the moral, and the other one is sort of the understanding of the statistical information. The statistical information is more challenging because I think this country and some other countries have not really spread education very broadly. There are a few people who understand probabilities and most people do not. Some of the things like predictive models, classifiers, this is an educated audience, but most people have no idea what this means and what the limitations are of that. I absolutely agree that some of that education has to happen, and it can happen through the very media that even people who don't have a college degree would actually access, if only our news media were one of those channels. But the other side is the moral, and this is, that goes back to the question about liability as well. So some of the work that we are doing is actually thinking not only about the ethical questions of designing robots and implementing them and keeping cycles of revision as you get feedback from the users, what works, what doesn't work, what they feel comfortable, what they feel uncomfortable about, but also trying to build some of those fundamental norms of interpersonal behavior into the systems themselves. So a polite operator, for example, implements a norm that we have, namely to be polite to each other, not being cold, not being angry, responding to that. A robot that is in somebody's home cannot just roll around and coldly respond to, oh, you've fallen, I'm going to call somebody. But rather, they will interact. Otherwise, you don't want to have this system around. So I don't think that's the level of government. It's the level of science and technology development, engineering, and the marketplace to really take seriously that in designing these systems, we have to be able to implement the kinds of fundamental norms that we, in a sense, impose on each other. And that's not an easy undertaking. That's a huge, challenging scientific question, but I don't think we can skip that.
I found your question really interesting. I don't know anybody who is working on that. And if you can think of creative ideas, then go for it or pass them on to somebody else. But I think there's one thing about what the moral responsibility is. It's important to know there's a breakdown in our government's ability to keep track of all these disruptive technologies and stay on top of them. It's called the pacing problem. That technology is emerging much more quickly than we have the oversight structures to respond to it. Just to give you one example, the FDA looks at a lot of these things as devices that need to be tested and proven before they can be deployed. The problem is when we start talking about these digital technologies, they're constantly being improved and upgraded. That would mean, and if you look, and the ones that learn are constantly changing in terms of what their performances are. So we get into this weird situation where the FDA would want that device to be approved every time it goes through an upgrade, but the approval process would take 6 months to a year and a half. And yet the improvement, even if it's just a modular upgrade, is often every 2 weeks, but is constant if it's a learning algorithm.
Let me say that the FDA and intelligent reasoning systems have had an interesting relationship over the years. In the 80s, there was a move by one of the offices to regulate and make medical expert systems devices. That was cut down as being inappropriate. The argument was that these reasoning systems were like books, and books aren't regulated. This might change, and so I don't know where things are these days with that discussion. I know at one point in time there was concern among the researchers trying to develop these systems that kind of regulation regulatory activity would suppress research and fielding of technologies. But I thought your question was really interesting. I wish I had, I was thinking, boy, I should have taken a pad of paper here to write down all the pieces, because you can dissect it into many pieces, and we can discuss each one separately. Let me mention one bit of research that maybe is the kind of thing that Wendell was looking for, that we did and published about a year ago. We were curious, could we study how people searching the web for medical information, how their beliefs about causes would be updated by what they were reading? So we're studying a model of human belief as a human as information processor with signals coming from the web based on search terms. You can read about that. It's a lot of work. The first step will be characterizing where we are today before we can try to come up with notions of well-calibrated humans reading information. And of course, that will bring up lots of questions as to who's calibrating it, and who's persuading, whose ideas are at play, and who makes decisions about that.
Okay, we have time for 2 quick questions. I'm sorry, this gentleman right here, and then one up front.
Hi, so I'm going to take a little bit of a contrarian view to some of the views expressed on the stage.
But they're already contrarian, I thought.
Contrary to the
There's room for a 4th dimension.
That's right.
Contrary to one of the views there. So my question is, can an AI bot actually meet some of these human needs like empathy, comfort, social isolation, traditionally provided by a healthcare provider? Now, I ask that because a lot of healthcare providers are not very emotionally intelligent or empathetic. And even if you look at applications like mental health, and I guess like the second point is that maybe we've seen this out in the wild with Microsoft's chatbot in China, for example, where people have actually told it, "I love you," as an example. But is there applications in healthcare where, when we even talk about the cost of technology, that they could be deployed in a remarkably distributed way?
You know, really briefly, John Markoff covered a little bit blog story on that medical Beijing kiosk a few years ago, and he had a doctor's quote, "Boy, I'm glad that thing is showing empathy. I have no time for that."
So what you're saying is the bar is pretty low.
Yeah.
The bar is low, right.
That would actually say, oh yeah, AI is already doing pretty well. But I think we should not stay at that point. And the hope is that by having more time, by actually having it as one of your professional roles to talk with people rather than just transmitting medical information that people don't understand. That the whole selection process, who goes to medical school, who's successful, who becomes a doctor, shifts. Those are unintended consequences that might be positive.
Well, I have to say, I'm on an admissions committee, and there is a shift towards physicians who can really have a very normal affect.
And they
really
want to.
They
when
want
you
to,
talk to
yes.
physicians, they actually want to have the opportunity.
Well, but there is,
Many.
right, I think it wasn't always a quality that was screened for as closely as it is now.
Yes.
So,
but implicit
one
in
more
your,
question here. Yeah, I'm sorry, go on.
But implicit in your question is, will they be empathetic? And the fact is, there's no one home. They may express empathy, but will you be happy with the authenticity of it, or will many of you be turned off by it? So oftentimes, whether that form of empathy works or not has more to do with the eyes of the beholder than anything we can program into it.
Okay. One more question here, and then I hope to get a very short summation from each of our guests. Yes.
Search giants kind of like Google are now using popular softwares online to deliver a wide assortment of care for people based on their, I guess, their search history, etc., kind of doing a bit of machine learning on their own. And you, Eric, talked about cyberchondriacs who spend time on these diagnostic softwares like WebMD, for example, which Google is now starting to harness. And for someone of your ambitions who has studied these anonymized search query patterns, do you think that there should be a move to link IP from computers to such softwares like Google to lower the cost of healthcare or possibly make it more machine-based, or do the ethics in cybersecurity outweigh this? What are your thoughts?
So I do think that there is a lot of there's a bunch of opportunity for doing more things online. As to who's going to do it, that's an interesting question. There's a bunch that can be done. Unfortunately, you can read more about cyberchondria. The way the web is indexed today, and the way, including how strongly signals are taken as to what's clicked on as feedback, that's the correct answer. You can see one just think that through. You can see one source of where anxiety would come from when the top end results coming up for your twitching thumb or eyelid is ALS, because that's when people are clicking on, and that's the signal for correctness. There's a lot of work to be done on how medical information is indexed and ranked. So even an initial pass at that would be valuable. Let me just say that one of our papers studied not just the people getting anxious and how long they stayed anxious for. It was people that end up clicking on like neurologist Bellevue, Washington, 98052. Often the last query, we call this a healthcare utilization query, which shows this probably with a significant link to money being spent after the anxiety has come to the fore. So we have a lot of work just to get the basic web working to give proper information. You know, try inputting chest pain sometime into the web. It turns out in this paper, in the cyberchondry paper, it took me as a trained MD about a day and a half to figure out what the probability is in a 45-year-old male with a first experience with significant chest pain. What's the probability of a heart attack? Turns out it's much lower than you think, but depending on where you go on the web, you get very different answers. Anyway, so yes, someday potentially, but I think right now we have lots of work to do to clean things up.
Okay, guys, I'm afraid we're out of time. So Bertram F, thank you for your information today. Wendell Wallach, Eric Horvitz, and thank you for coming and hearing about artificial intelligence. And thank you to the World Science Festival.